Right, if we could get the panelists back up. You know, picking up on sort of what didn't happen in the waiver that we all wanted to happen. And so, aside from crying over spilt milk, that moment came and went. And so I want to ask it in this form. So Mitch, if 5 state Medicaid directors were in a bar together with a couple of people from CMS, what's the conversation like that stops this seemingly logical connection from finding its way to an actual funding situation? What is it that people say when the housers aren't in the room that we need to understand about what's sort of blocking progress?
I think the people at Medicaid actually agree that this is the right thing, but are unwilling to stake it out as a position. The arguments against it are not, in my opinion, very strong. The strongest arguments against it that you hear are that it's putting a pressure on Medicaid to do too much. That Medicaid is already growing as a program because of the ACA. And that, you're asking Medicaid to house people. So soon you're going to ask them to transport people and to, do all sorts of household help. And what's the line? I think there is a less intellectually satisfying siloism which says, that's HUD's job. Why should we spend our resources, our capital? Let HUD do that. And there is nothing to preclude that, right? There's nothing except that it's not going to happen because it's a different source of money. And so it's just not right, which is why we believe what we believe, which is go where the money is. So, I think, and maybe it goes back to what you said, it's a leadership issue. If Congress or the president felt strongly, there is nothing that actually precludes this other than the willingness to do it.
So there's a sense then that I think, as Mitch is saying, it's not so much a question of whether or not this makes sense, much as just sort of what's the slippery slope piece. I've heard that over and over again. Steve, do you have any thoughts as a healthcare person?
Well, just as having talked to people in state Medicaid agencies and different agencies, there is a real siloing, and people don't want to give up any of their authority. So housing would probably be happy to have some healthcare money, and healthcare would probably be happy to have some housing money, but the idea that one would give money to another just rubs the administrators in those agencies wrong as well. So there's a bureaucratic issue in addition to the policy issues, I think, as well. Really need to be overcome.
Got it. And Sharon, you having survived one Medicaid waiver process, or maybe that's your second. I don't know.
It is my second, unfortunately.
Okay, all right. Well, you're making progress. What's your insight from having sat through that process in terms of what you see as sort of what were the final barriers? Was it as much about the state's unwillingness to put money in the system, or was it as much about this kind of siloized thinking process?
I think it was actually the state seemed pretty committed to the idea that they really wanted to use Medi-Cal to pay for housing. But I think the issue came to the federal response, and the federal response was pretty strong. They drew a line in the sand, and I think what Mitch said is absolutely accurate from what I've heard from people at CMS. They think it is a slippery slope. Where do you draw the line? We don't want to become housers. We don't want to pay for rental subsidies. That's never ending. So all of those things I've heard. They do cite a regulation about not being able to fund room and board, but of course they do that. So I think that is almost like an excuse or a reason that they are using. But I think the informational bulletin that came out before California's Medicaid waiver was approved really was an attempt to respond to several states, not just California, but several states talking about using Medicaid to pay for housing. And I think they just wanted to cut off the discussions, and now it's considered kind of the final decision. I do think that it will take congressional action clarifying that Medicaid can be used to pay for housing. I think that that's probably what it will take to overcome the reluctance.
So Sort of on that thought, and Steve, maybe I'm going to go to the historical side of you if you have one. So I'm hoping it's there, which I didn't ask you this in advance, but sort of we had this strange situation in which we've defined health, and you sort of referenced this earlier in very medical and clinical terms, and sort of how's that come to be, and is that sort of a permanent feature of our healthcare system here in the United States? Does it compare to other places in the world, and Mitch, maybe you want to jump in here too, like how is it that in the U.S. we've come to define health in such narrow terms, at least in terms of funding?
The funding is historic because the way we finance healthcare is unique in the world, which is through employment, which is a result of pushback from the AMA on the idea of universal health insurance, and then World War II, when there were wage and price controls, and the way that companies were allowed to increase their wages was by giving benefits. So when you hear about, the problem of Cadillac health insurance policies, that's actually a legacy of World War II and the way that we structured our healthcare reimbursement system. The problem now is that everybody so there's a discussion about wanting the state to have some skin in the game. There's so many actors with skin in the game that everybody sees moving things around as a zero-sum game. And so I think that creates problems because you're working with established actors. So if you want to take money out of Medicaid, the hospitals and nursing homes and doctors will yell because they don't feel like their reimbursements in Medicaid are very high, and they're not compared to the rest of the country. So if you looks like a lot of money until you start dividing it up among all the people who rely on that money. So then they're going to have a pushback. So it's the interest group politics part of it, where everybody's already got their piece of the pie, and trying to redistribute that pie creates problems.
So Mitch, in your kind of budget side, sort of as you think about that, conundrum that I think Steve just referenced, sort of as we think about the fact that we have to spend some money to save some money, but it's not necessarily the same person that gets the money. We've got a lot of wrong pocket issues, sort of from your budget experience and your role, in the health system, sort of what's true about that, what's overcomable, how have people found a way out of that for comparable situations, or are there other ones?
Well, I believe that Sharon's good work will not go without success. I just think the two waivers weren't it. That it may be a third, or it may be, but we have made progress. These are levels of conversation that did not exist 10 years ago. We never got as close before, right? This is how social movements happen. I think at your broadest level, you're asked, to me, it's a social movement question. How do you make a cataclysmic change? And what I believe is that it'll be my generation, the baby boomers, who will resist going to nursing homes. And we will say, what are you, crazy? I'm not going to that nursing home. Do you know what happens in nursing homes? Right? I'm not giving up my independence. I refuse. And if enough people absolutely refuse, because remember that almost nobody saves enough money to live very long in a nursing home, right? You have to, even let's call it, $50,000 a year, right? So ultimately, right, that's what it costs, right? So everybody goes to Medicaid pretty much, right? Because even if you save 30,000, 40,000, 60,000, 80,000, you're going to go to Medicaid, right? So now, we the baby boomers, right? We have had a different kind of life than our parents did, and we have different expectations of our rights and our independence. And I think for this to change, it requires a social movement of us saying we're not going to a nursing home. We refuse. We will not go. We demand that we be allowed the same amount of money that the government would have spent to allow us to have home care. And that and then you ask, so well, how's that going to happen, right? And the only way it's going to happen is through the Medicaid. And that will be the social movement that will put us over the edge.
And so, Steve, just you had earlier said, you pointed out that, Social Security costs already eclipse housing costs. So for some group of people, not all of the boomers, but for some set of folks, we're already at this critical stage, right? So what's stopping that from being a key political factor in actually moving this dial? I mean, why isn't what Mitch describing already happening?
So actually, California does puts more Medicaid dollars into home and community care than nursing home care. It's it's like number 4 or 5 in the country in the balance of community-based care versus nursing home care. But if you can't afford your apartment, it doesn't matter if they'll send in somebody to help you cook and clean, you're being thrown out of your apartment. Or if you're in a so we did a study a couple years ago of people receiving in-home supportive services and the challenges they faced in remaining independent. There's a woman in San Francisco who was in a 3rd floor walk-up, and she was unable to go up and down the stairs. So her home care worker was able to go shopping for her, but if she wanted to have any other quality of life, like if she wanted to go out and visit family or be involved in the community at all, she was basically barred from that because she was in a 3rd floor walk-up in a rent-controlled building. So she had if she moved, her rent would have doubled or tripled, right? So she was trapped in housing. And I think that's the situation both for some seniors who own their homes, that it still costs for upkeep and utility and taxes, but if they think about moving to somewhere where services are better located or closer to public transportation, then their housing costs go up. And then in the few cities where there is rent control, people end up being trapped in housing too. So it's both the in-home care as well as the home.
But just so people understand, and you correct me if I have it wrong, while California is good, as you say, on the community services, we do not have an assisted living benefit under Medicaid, even though, how many, I think it's 15, 17 states have an assisted living benefit under Medicaid. And assisted living really does, because assisted living is independent, right? It does do a better job of breaking through this supposed line. And so, that's what I mean about the movement, because what you're describing are people who can't really make it in their existing apartment, but who have the right to something short of the bed in the nursing home institution where someone else tells you when it's breakfast time. Right. And so, the demand has to be, we demand, all these other states have assisted living. There's no prohibition against assisted living. Why don't we have assisted living?
Mm-hmm. And so, Sharon, as you think about that from a perspective of lobbying in Sacramento, I mean, the push that Steve and Mitch are describing, I mean, what's your sense of how that's felt in the legislature? Do you experience anything like what we're optimistically describing as sort of like what would get us over the top when you're walking the halls? Do you feel like there are other people rowing in this direction?
Yes, some, but I don't feel a tidal wave yet from the rowing. I think it's really been a few people who champion homeless issues and are strong on health care, who are thinking about how can we change our Medi-Cal system. But I think we have to recognize too, we have an administration right now who doesn't want to spend state dollars for anything new. New programs are not favored. So thinking about how we spend, right now we have a big state surplus of revenue expected. And I think a lot of legislators and the governor are thinking about how to create one-time investments, but there really are no discussions around creating new programs that would require ongoing investment, even if that ongoing investment saved money over the long term. So I don't hear anybody talking about new assisted living benefit or anything like that. There is a lot on the plate of the Department of Health Care Services. There are a lot of new programs that they've taken on under the Affordable Care Act. They've tried to take advantage of some of the new innovations that were made available under that, but really not very much in terms of trying to link in strong housing or social services into how those programs operate. So I think there's discussion about it, but not to the level that it would need to be to
Right.
really change
So,
the current system.
and there's obviously not very organized constituencies or powerful constituencies yet. The one that you
Right,
described,
you need
Mitch,
seniors, right? You need approaching seniors. You need all of us saying we're not going to nursing homes. If we can't make it in our house, We need assisted living, right? And again, the big distinction is that if you can make it in your own home, everybody wants to make it in their own home. But if you reach a mobility issue or a social interaction issue, you want your own place, but you want it somewhere where you can get everything else you need in a safe place, including someone to call when you fall down, right? And that's what we're going to demand.
Right, and I know AARP has gotten interested in this to some extent, but obviously one of the challenges for us, I think, in the housing world is that we're not a very consumer-driven group.
Right.
And so there isn't like a huge pool of folks sort of actively participating in politics, through many of our constituencies. We tend to focus on the producers of housing or the service providers and aren't necessarily great at harnessing the kind of latent political power of folks that are out there. I don't know if you have any, I see Steve's nodding his head, and maybe it's just an observation that's so obvious that we move on.
No.
Oh, go ahead. I was just going to also touch, I agree with that completely, but I was also going to touch on a point that Steve made about our fractured funding system for healthcare. There really is no incentive for anybody, for any industry, segment of the industry to go to Sacramento and say, we need to get more money for housing for, our members or our constituency. Because the funding the way funding works in the Medi-Cal system is so fractured, it's really difficult to capture savings and reinvest it. So that, I think, the complexity of how Medi-Cal is financed and how it finances providers just makes that also very difficult. Because I think the healthcare industry as a whole is very powerful in California, just not the way financing works. It's just not in the hands of one sector that would go and advocate for that.
Steve, did you want to?
Yeah, I was just going to get back to the issue of constituencies. So voter turnout among low-income people is historically lower than among high-income people. Among young people, it's lower than among older people. But that doesn't mean that they are not organizable. And so there are lots of organizations. PICO does low-income organizing. There's an organization near downtown, I believe it's called SAGE, that works with housing and housing rights. And when there are organizers who show people a route to making a difference and then have some short-term, Zelensky, have some short-term wins to say, yes, when you raise your voice, you really can make a difference, that the sector is organizable. It just doesn't self-organize. So maybe that's a call to all of us.
Fair enough. All right, so with that gesture at the audience, I'm going to take that as a cue. All right, so I have many more questions, so if you don't ask them, I'll ask mine. But I just want to open it up and see if there are questions. I see a lot of people in the housing world and health world. And maybe actually, I meant to ask this earlier. Of the folks here, who sort of self-represents as somebody from the housing world? If you could raise your hand. Okay, how about from the healthcare world? Okay, good. All right. All right, so questions, folks that have thoughts, questions for the panel? Mr. DeKalb.
Being a home affordable housing developer of affordable senior housing, we've been paying attention to a lot of things that have been going on around the nation. And as you mentioned, there's somewhere between 10 to 15 states that have already broken through this barrier, and they are now using Medicaid funds to help develop or redevelop, even in some cases, call it independent senior housing, right, into more of an assisted living type of complex. And my question is, there must be some pretty good models and statistics and numbers that they had to use, right, and that now have grown from, because we heard about this first 3 or 4 years ago, where they first started coming out in the Midwest. To be able to utilize that in some way, because granted, I'm all with getting the money for the homeless and all the services that we need for all types of affordable housing. That's pretty, that toll is very large. But if you start with something that makes a lot of sense, because right now we know statistically in our communities that about 25 to 30% of our residents are already using in-home services that Medicaid is paying for. And so we know that if we can build that infrastructure inside of our community, we can do it a lot cheaper. Let alone the arguments for keeping them out of, nursing homes that, by the way, are probably more like $100,000 a year versus $50,000 in California. And so just, the argument
Yeah.
seems like it's right there, I just don't understand, what is the Medicaid, what is?
All right, so there is one part that speaks to this, because I had this fight about the nursing home issue in San Francisco. So, as irrational as this sounds, you've already heard California is very low in its 50% contribution on Medicaid, right? So every dollar that the state could get the feds to agree to, they have to put up 50 cents. So you say, well, but assisted living, why wouldn't you do that? It's less expensive than nursing home. The answer is very sad. The answer is that the state knows that there are many people who would rather live in unsafe conditions, completely isolated, than give up their independence. And they basically don't want to create nice places to go to, because that will be more expensive than leaving people in the horrible, isolated places. I mean, the thing I was wondering about when Sharon was talking, that the easiest pilot that could overcome that would be if someone, would make as a leadership issue, I'm going to take the 17,000 people and I'm going to move them into assisted living. The 17,000 people,
Okay.
Sharon, that you showed that are already in nursing homes. So in other words, if you approved, some community partnership, with groups like you and Mercy, and you said, these 17,000 people for whom we're already paying 50 cents on the nursing home dollar, you can put into assisted living, that would actually be a winner for the state. What the state is worried about, even something like that, is that would be the first step to then saying, okay, assisted living. And if you say yes, assisted living to everybody who meets nursing home criteria, you bring in all these people who, like me, would refuse to ever go to a nursing home. Right, so it's called the woodworking effect, and that's what they're worried about.
With
That argument, given the fact that we know statistically where we're going with the population right now, of the over 60, over 70, over 80 population, that 17,000 is likely to turn into 34
Yes.
overnight. And that, we can prevent that. Like, it's harder to get, I hear you, your argument's a great argument. And
It's not my argument, I'm totally against that argument.
I mean, I mean the argument of,
Right.
I can go out tomorrow and try to help solve the problem to get the 17 into the right type of housing, tomorrow, right?
Right.
But we've also got this other argument of the growing problem.
Right.
It's just, and it's inherent, I mean, it's not like, somebody can say, oh, that's not gonna happen.
Right, so, Sharon, I know you're gonna jump in, I'll just say, we spent a fair amount of time on this a couple years back, and it went so far as to hire health management associates to kind of help us understand this issue. And the conclusion we reached in talking to the Department of Healthcare Service was that partly because of this woodworking kind of induced demand issue, that was very terrifying to people. The other issue is, as it relates to homelessness now, and I don't want to overemphasize the scientific nature of it, because there may be people here who have more knowledge than I, or many people here. But there is a sort of predictive modeling aspect of homelessness and sort of who represents the most expensive folks that I think is at least reasonably well established and on balance gets us reasonable answers. And what we discovered in working on this issue is it's very hard for the medical world to understand which seniors are going to become expensive. And so which ones are going to hit the nursing home system. And for that reason, in our conversations, and we talked a lot with some of the folks in the room, is easier for them to do what Mitch just described, is to move the people out first, because that's an expense they already have today. And a lot harder for them to predict who's going to become expensive, because, at least as I understand it, you don't really become expensive as a senior until like the month before you become extraordinarily expensive and end up in a nursing home. So it's not a slow build necessarily, or there aren't a bunch of clear factors. But Sharon or Steve, do you guys want to add to that?
Oh, I was just going to jump on what Mitch was saying, that, when you create a new benefits and entitlement, you can't limit it to people who are already living in the nursing home, because it would be an entitlement that would be available to anybody who's eligible for the assisted living benefit, which is much broader population. So I absolutely agree that that's the biggest fear, and that would be probably hundreds of thousands of people in California who are on Medi-Cal. The other complicating factor is a lot of those people are also on Medicare, which is 100% federally funded. And so when you have that dynamic going on, that complicates things even further, because then you get into who's paying, and it has to do with how long they're in the nursing home. You don't know how long they're going to be in the nursing home when they're admitted. So I think all of that, it makes it very difficult for California to embrace that. And they really do not, the current administration, and this is not just the current one, but going back many administrations, they do not want to invest state dollars. They're fine if the feds are going to invest the upfront cost, but the state does not want to invest state dollars in new programs.
So the bullet train, Mike, that's what I've heard many people say. We're
Yes.
just going to put people on the bullet train as an alternative to nursing
That
homes.
is
It'll be a
our
very, very
affordable
nice
housing
car,
plan.
great meal service, way better than anything you're going to get elsewhere. All right, other questions? Tanya?
I just have a question that most of you have touched on the issue of homelessness in Los Angeles right now and the benefits that will be available through these multiple acts. What are your feelings on how we will outreach to the thousands of people that are on Skid Row that either don't go to doctors, don't know they're eligible, and currently use the emergency room as their primary care physician? So there's a lot in place of how we as groups talk to each other about this and how we gear up to meet this. But what I'm struggling with and my organization struggles with is how do we let people on the ground know that these opportunities are there for them and then ensure that they're able to get access to them.
So since it's LA, I'll try my sense of it, and then we have two very smart housing people who can critique it and give us better suggestions. The thing that I believe has been missing in LA, and I think we're getting closer to it with the work of the county and the city, is what I'll call a business plan to end homelessness. A business plan to end homelessness is different than you're going to do a really good thing for homeless people, and you're going to do a really good thing for homeless people, and you're going to do a really thing, and you're going to 75 people, and you got 100 people. I think in part because of fear of the final dollar. Nobody, in my opinion, has really said, and I have been pushing this, and I think we're getting closer to it. I want to know what it would take to end homelessness in Los Angeles. The whole thing. I understand that it won't be tomorrow, but I want to know, the inputs are relatively simple. I need to know how many units are vacant, and you can't use standard vacancy statistics because they don't include units that are off the market. So I need to know really how many units are vacant and what it would cost to rent those. And I need to know how many units have to be built and over what period of time and how much that would cost. That would give you a final cost of what it would take in Los Angeles to house all of the homeless people. Then you would parcel out to government, the nonprofit sector, the housing builders, each a part of this. And then you would have a whole solution. And everybody would, under that scenario, would be focused on housing. Because what the early analysis, both by the city and the county, shows is a lot of money is being spent on the homeless to not house them. Huge amounts are being spent that are not housing people. And, it is always easier to create a referral center and an assessment, a vulnerability index. I can't tell you how opposed I am to vulnerability indexes. I'm like, they're homeless, house them. Okay? Is it really so important? Do we really want to spend money creating the list of, okay, she's 2,274 on the list, and he's 3. Let's just, as people come to us, house them. I think that if we ever had that full plan, and again, I've been pushing people, and I think we're getting closer. I think you could also get business involved. I think the reason business is not involved now, even though they have tremendous gains, think of all of those hotels that are bordering the area that you're talking about. Think about what that property would be worth. Again, cold cash to those people if Skid Row looked different. The reason you're not getting them involved is because they don't believe that the government and the nonprofit sector will solve this problem. And the reason they don't believe in it is because the problem is visibly getting worse. It's not our fault. I think a large part of it is the drop in the state prison population. While the county jail is up and steady, the state prisons have decreased the number, their population. And you have more people on the street. I think the lack of jobs for very low literacy people, right, no longer exists, right? The men who would have once worked at the dock or would have once worked in warehouses, those jobs don't exist. Even the McDonald's job requires that you work a computer that's fairly sophisticated. So I think there are a lot of issues. I think the meth epidemic, you know, the fact sort of very cheap, very potent drugs. But I think if you ever put it together and said, this is what it would cost, what the fear that people have is that the sticker shock would push people away, I think you'd have the opposite. That if business vetted that plan and said, this is a good hard-nosed plan to end homelessness, and this would really work, they would put up the money. And then if you added the nonprofit and government and business, you would solve it. That's my view.
Sharon, do you want to offer your hard-nosed critique, or Steve? You want to tell Mitch where he's wrong?
Well, I was just going to add, I think to take advantage of these opportunities that I was talking about and that others talked about, I really do think it does require thinking about really trying to scale up, not just in terms of money, but in terms of capacity. Because I do think most nonprofits right now, they do not have the capacity to take on providing health home services and doing the administrative work that they need to be able to do to take advantage of that benefit. And so I think the whole person care pilot actually offers some opportunity for the county to try and build that capacity and really, you know, be training a lot of outreach workers. We're thinking about using a lot of people with lived experience. How can we use that resource to do a lot of outreach under new benefits or opportunities that are coming up? But it really does take the kind of planning that Mitch is talking about, I think, you know, just for that capacity building and trying to figure that out and how much would that cost, and how do we go about doing it. So I think that that is kind of just an answer to your one question about the specific opportunities that are coming our way. To take full advantage of them, I really think we need to be thinking outside the box in terms of how we ramp up our own industry.
Sharon, do you think, just as a follow-up, because this is good advice, and I'm interested in your opinion as well, or anyone here, do you think that the full plan, which would show, because I totally agree with you, the capacity, the number of units, and then the final dollar and time, right, because this would not be something that would happen tomorrow because you have to build units. Do you think that the effect of that would be to scare people away because they would look at the number and say, wow, that's just too much money, that's too much effort? Or do you think it would bring people forward to parcel out, okay, so here is the plan, you're doing this, you're doing this, you're doing this?
I think right now we're at this opportune time where there's tremendous momentum. So CSH, actually, other staff in my office did some financial modeling to really try and figure out what you're talking about. And I think the initial thought was, this is really going to scare a lot of people. But I think when presented, it really ended up not scaring as many people as we initially were worried about. Because right now there's so much attention and thought being put into how do we solve this problem. I wouldn't want to waste the momentum we have now by being worried about scaring people.
Yeah, I think that it's the scare that has kept the plan from being, I mean, because there are people with portions, but that's why there's no public plan. Because the fear is that the public plan would scare everybody. And everyone would go, oh, see, we can't do it. But I think now I'm with Sharon. I think I would have once felt that it would do that. I don't feel that now.
Let me ask, can I take what, do you want to do a quick follow-up?
Instead of a follow-up, do you think, because I'm a player in this world working with both of you, that the issues around downtown and the regentrification and what real estate really costs cash to be king for that in LA has an impact on people being afraid of what it would cost to do this work, or they don't want to do it because they'd rather spend dollars on luxury, market rate and luxury housing?
I think we have to harness that luxury. I mean, what I think it was Mitch who was talking earlier about, trying to do some inclusionary. It's so critical at this moment in time to pass up the opportunity to do something like that when we do have some momentum again going forward, talking about if you just had, for every luxury development that goes up and downtown, if you had 10–15% of those units dedicated to supportive housing, or even units that are 30% area medium income units, that would make a tremendous impact. But we're not, I think we are afraid to be a little bit that bold, so I
It
don't
would
know
need
what
to
your
be
thoughts
part of that plan, is my view, is that one of the elements of the plan, right, and again, it's the same issue, is it's hard to get the political support for the inclusion, because the other side says, well, it's gonna stunt the development, and nobody is saying it would end homelessness, because no one believes that anybody can end homelessness. They believe in our good deeds. They do not believe, the public does not believe that we can end homelessness.
All right, I'm gonna go to Jonathan, and then I'm gonna got one more question, and then I got a parting question for you, or some comments. Jonathan, you were gonna.
When we talk about it, it seems overwhelming. But when you say, Dr. Katz, when you say we got to have a business plan, we got a roadmap. Thank you. I thought I was loud enough that everybody could hear me. But we have to do it incrementally, because if we wait for this roadmap and we wait for everybody to get on board, it might be, I don't know how long, but it might be a little bit longer. I mean, right now we've come up with these waivers, and we have mechanisms. I mean, I would try and put the political pressure on the state to expand the waivers, expand the capacity. Right now, we do have an assisted living waiver for both public subsidized housing and for assisted living facilities, but it's capped at 3,700. It's almost full, okay? And there's 11,000, everybody agrees on that number.
3,700 people. Is
What's
that
that?
what, do you mean
37 slots, right? 3,700 people are in this. And, we all quoted that 11,000 number as Kaiser Foundation says 10 to 15% of the nursing home population does not belong there. So, I would look to, I'm sorry, I'm preaching. Yeah. I would be looking, I guess I'm acting like a rabbi today.
You're good.
I'd be looking to expand the waivers, put the political pressure there, because you already have a mechanism, they're already approved, and then build on the vacancies, because there's just not.
Well, so I don't think that the plan has to take a long time to develop. I think you could develop, I think the people in this room could develop the plan in 3 months. I think what you would do, like any political document, is if this group says, well, we're not willing to do that, then we say, well, then the plan doesn't work, right? The plan involves all of these different elements, right? And the plan, again, you can't, because there's housing stock issues, it is like a 5-year thing. Right.
Yeah.
So, I mean, you can't, we don't have enough units right now. So you're going, but the question is, what I don't like is that if we say, well, it will take years to develop all those units, well, people in this room, we've all been at it for years. Right? If we had started 20 years ago, we'd be done now. And the last analogy that I'll use, which I find helpful, is think about Hurricane Sandy, which devastated so much of the East Coast. Was everybody's response? Too bad. Guess you're going to be homeless. Too bad. Sorry your house was washed away. Sorry your community was washed away. Do you need some tents? We could get you some tents. No. Now, people did not repair the destruction of Hurricane Sandy in 6 months. But everybody's expectation was, and is, because some of it's still going on, that everybody will be made whole. Nobody's going to be left homeless because they were made homeless by Sandy. Because the expectation is that your government, FEMA, the nonprofit sector, the private insurance companies, everybody is going to work at this until it's all back to the way it was. And it's about 85% back now. Nobody says that about homelessness. We just accept all these people are going to be homeless. It's really, really hard problem. But we would never accept a natural disaster that created the same number of homeless people who weren't previously homeless. We would in any community, whether it was Beverly Hills or South Central, if a natural disaster made the same number of people homeless as are in Skid Row, we would never have the plan that those people are just going to stay homeless, or we're going to do this wonderful thing for 200 of them. We would have a plan to house them all.
Right. All right, I'm gonna take one more comment, then we're gonna go to now everybody wants in, because we went to the natural, but you were so enthusiastic. All right, quick question or quick comment. All right, well, I got you. You look so enthusiastic, and then I'll come over there.
Hi, my name's Nyasha. I'm with Neighborhood Housing Services of Los Angeles County, affordable home ownership creators and sustainers. I feel when I'm listening to this, especially your work, Sharon, as housing kind of grassroots advocates on the ground, I find myself going to public health meetings and then running to housing meetings and working with SAGE and all these organizations, but people are not working together. But we get it. I mean, we see the effects of mental health and foreclosure and losing a home or living in a lead-poisoned house. I guess my question is, what do you want us to do on the ground? What can we do more as advocates who are really touching people every day?
Okay, so can I redirect that for one sec? Because I think I heard what you said, but so I want to ask a slightly, because we talked a lot about sort of where does this go from an advocacy perspective, but I think there are some things that we can do today, right? And I think one possibility of your question is we don't really know how to talk to each other quite yet, right? And so let me put it in the form of dating advice. So you're on the healthcare side, Sharon. We're gonna say you're more on the housing side.
Yeah.
But regardless, you've spent some time dating some health people in the Capitol. So for the housing folks in the room, what's the dating advice that you're going to offer us here in terms of how do we close this gap? How do we better understand and actually find some things to do tomorrow instead of next year or next decade? So I'll leave it to you, whichever one of you feels most competent at dating advice. Mitch isn't even looking at me. He's like, I'm just disgusted by this question, is what he's saying. But I'm going to go to him now because he's not looking at me. All right, or Steve.
I mean, I think that it is the common constituency. I guess in that sense, I'm going to change the question and say, really.
I did it first, so you can do it. Yeah.
So really, the issue is that neither health nor housing has developed the constituency that exists to say this is intolerable.
Okay.
And
all right.
that we all need to be working at that constituency. And that part of maybe the dating problem is that I don't have the answer, and Sharon doesn't have the answer, and then everybody gets a little frustrated and we wind up at the same circle of meetings talking to the same people. Yeah. And that the real people we need to energize are the kinds of communities, whether it's seniors or people who have build communities following natural disasters and understand what it means to house 20,000 people. That those are the kinds of people we need to bring into the discussion.
Okay. So, and just for folks that don't know, I mean, it is possible to go out to your healthcare partners and ask them if people in your community or in your building or whatever are in their plan or whatever it is. And we've found some success with that, although I think it's surprising how little some health plans actually know about who there is. Steve, do you have any dating advice?
I was just going to give the example of the coalition between SAGE and Esperanza Housing Corporation and St. John's Healthcare. So those are three organizations that worked together over the last 15 years to deal with housing and health. And they work together, but it's a long-term relationship, right? It's not a one-night stand. They trust each other. They say, oh, this is a healthcare issue. St. John's, you put the grant in, and we'll all work together. Oh, this is a housing organizing issue. SAGE, you put in the grant, but we'll still, we'll work together. So I don't know how that started, but the CEOs of each of the organizations have a very close and trusting relationship. So I think part of it is just making sure your missions align and then seeing where together you have a greater impact than working independently. But it's not a
So it takes time. There's no Tinder for the health and housing set.
But there are examples.
Right. Right.
It can work.
Okay. I'm just trying to keep it, good, right? You appreciated that, I know. Okay, all right. Sharon?
I would say also really understanding the other's perspective, and this is good dating advice, I think, too, that really trying to understand what would motivate the other silo or the other system that you're trying to bridge. I do think it's absolutely true that you cannot expect anything to happen overnight, that it takes multiple meetings and encounters with multiple different partners to make inroads, but really trying to understand where each is coming from. And I think it's perfectly reasonable to ask people working in the health sector, are you willing to go to Sacramento with me and lobby for housing money? I've not been successful at that yet, but there are a few people
Come
who
on,
have
you
been
have.
doing it. I mean,
Dignity Health has gone with
Health,
us. We've had
yeah,
people come
every
with
year
us.
now for the last 3 years.
I didn't even know you were there, but that was just
Oh,
the,
there,
yeah, there it is.
Rochelle,
All right.
thank you. Rochelle has come to lobby, made a special trip to Sacramento every year for the last 2 or 3 years. And I'm bringing her, we're having a lobby day, by the way, on April 12th, so all of you health people and housing people should come. So I think those small inroads, you know, trying to work together on something that I think the healthcare sector, I think, does realize that this is a problem now and is growing recognition of that. So trying to figure out how you could work together and which capacity.
All right, great. I'm not even going to take my dating metaphor anywhere with your, there are too many bad things that could come out of me on that. But, all right, last question or comment, and then we'll thank the panel, and if they have any parting words.
Yeah, just a quick question. I think it follows up well on also that discussion. Kind of just wondering about the role of accountable care organizations, bringing in the insurers, and perhaps in the sense of the cost savings, helping with that sticker shock question. But what's needed to kind of bring that to the point where we'd like to see those investments flowing? I mean, we have the legislative piece under the Affordable Care Act, but what's currently needed to kind of push that a little further and hopefully get the insurers in this relationship along with the housing and healthcare advocates.
So,
I think the challenge on the ACO side is just that the ACOs so far have been private insurance ACOs, and so have mostly hit the higher income people, and that the greatest problems are at the lower income part, and that the Medicaid ACOs really haven't taken off because Medicaid reimbursement rates is so low that it's not clear that there's any savings, because there might be saving money that no one was paying you to spend anyway, but there's not a lot of willingness on the rates part. And then further, it does, whether it's ACO or not, when the actuaries come, if you spent your money on housing, those housing expenses don't count toward your next year rate. So what will happen if you go and house a bunch of people is they'll say, thank you very much that you decreased their hospitalization. Now we're lowering your rates because you have less health care expense, and they won't give you the part of your housing cost because we haven't succeeded in getting around this Medicaid issue. So I think they could do more on the ACA. It's just that's not the highest risk population.
and that is the same trouble we're having with the nursing home situation, is if you get someone out of the nursing home who could, the work that Jonathan does or somebody else, boom, your rate gets lower the very next year. So thank you very much for all your work. Right, moving on. Sharon, do you have something quick to add, or Steve? No? I do think this is, sort of one of the things that didn't work so well in the waiver. I do think we didn't really get to a place where the managed care plans really have enough incentive, really, to kind of dig in on this issue. And I think it probably is kind of one of those things that's going to take a little bit more time. I know that when we started working on sort of payment systems 5 years ago, we thought, this is it. It's exactly what you're going to say. And we spent a lot of time going out to reach out to managed care plans. And it sort of goes to something that was said earlier, which is just the complexity of the payment systems, I think, really militates against a lot of these really common sense solutions. And so that's part of the challenge we've got, which is that I think just deciphering each other's systems is taking a lot of time. But I do feel, and I guess I'll just say for the panel, like the comment that was made earlier, there is a lot of progress being made. I do think that as much as we can do under this waiver is going to help, and that, our ability to kind of work with each other in real time and do as much as we can during this limited period, there is, I think, as much of a kind of political will issue as there is an evidence issue here, but there are definitely some issues relative to evidence and sort of just people having the confidence that it's going to work, that really only comes from working together on these things in the way that people have described. So does anyone have any parting words of wisdom or shots, or do we want to
Thank you.
Thank you. So I really want to thank the panelists and all of you and the Zeman Center and everyone else. I really appreciate the time. I'm sure we all do, and I want to thank everyone for joining us here today. Thank you.